We're going to talk about newborn. So here we go. Hopefully you guys completed all your modules, but we're going to talk about it in chunks of time from birth. So immediately after birth, we've talked a lot about this, the golden hour, getting that mom on that chest if at all possible. Really getting that mom to nurse in that first hour, because we know newborns have periods of reactivity and they are really wide and awake for that first hour, and then they conk out for the next 24. They are out. We're having to wake them up every 2 to 3 hours to try to get them to feed. And so it's really important to take advantage of that first hour. It's when babies bond with their parents. And so it's really, really important before they just absolutely can pass out. So one thing we do is an APGAR score. We've talked a lot about this. It's done at 1 minute and 5 minutes. And if it needs to be repeated, it's done at 10 minutes. And it's just a score that shows us how is baby transitioning to life outside of the uterus. However, we don't wait a minute until we resuscitate a baby. So APGAR score isn't really used to determine if we should resuscitate a baby, because by a minute, you should already be doing something if that baby's not breathing. However, it is just sort of a general score that's given to show how baby adjusted to life outside the uterus. And if they get under 6, we do it again at 10 minutes. So no baby ever typically gets 10, because every baby at least is going to have acrocyanosis, which is that blue extremities, blue hands and feet. So you guys need to know this. You need to memorize this, write this down. They almost always give you an APGAR to figure out. Sometimes though, if you can just remember it's 0, 1, or 2, 0 is bad, 2 is good, and you can kind of guess by the things they're telling you, you can usually figure out the question. So if you kind of think, okay, activity, is the baby crying and moving around? Pulse, is it 100, less or more or over? Grimace, again, grimace is like, I always try to think of a better word for that. Are they floppy or not? But I don't like the word grimace for that, but it's like floppy versus, not as floppy. They respond to stimulation. Appearance is color, and respiration is respiratory rate, but really just looking at, is there cry or not? And again, it's not done till the first minute. So in those first 20 seconds that baby's born, they may not be crying. They may be in that what we call primary apnea, that you stimulate and suction, and then the baby starts crying and pinks up. You wait until they're a minute until you give the APGAR score, because we know many babies are going to need a little bit of stimulation to get going in the get-go. So again, these are other things that are done. The APGAR score, you're going to do vital signs, they're going to do weight, length, all of that kind of stuff. They're going to look at a neurological assessment. And then these are things you look at. This is basically when you're resuscitating a baby. So you don't need to know this by heart. This is neonatal resuscitation protocol. But I just want you to look. So when the baby's born, were they term? Yes. Okay, so you're going to go to your, yes, you could keep them with the mother. Are they breathing or crying, and do they have good tone? Okay, good. No. All right, then you're probably going to go over to the warmer. And it sort of goes through this. So by 30 seconds, if they're not breathing, you're going to start giving positive pressure ventilation. Remember, I'm not even doing the APGAR until 60. But let's see, we give it to the mom, we put him on, we get the baby warm. We know skin to skin is one of the best ways. We clear the airway with the bulb syringe. We vigorously dry to get that baby stimulated. Are they breathing okay? Yes. Or airway clear? Yeah, okay, baby's fine. Oh, no, the baby's not really breathing and the heart rate is low. Okay, we are now at 30 seconds. We need to go ahead and do positive pressure ventilation. So look, for the first 30 seconds, you're stimulating and suctioning, okay? And you'll see practitioners feel for the heart rate at the base of the cord. You can feel it pulse. Why do we do positive pressure ventilation by that 30 seconds if it's not being done kind of within this block of time between 30 and 60? Because you need to know this. Babies go from primary apnea to secondary apnea, sometimes in utero. Primary apnea, most babies are born with. That's that sort of like, when they're first born, and then you stimulate and suction and they start crying. And that first breath is then opening all the alveoli. However, some babies who are stressed will actually descend into secondary apnea, and you can stimulate and suction all you want. Secondary apnea has to have positive pressure ventilation. I have often done positive pressure ventilation, and it's the ventilation that is often causing the heart rate to be low. And as soon as you do PPV, it all goes up and then they're fine. This is 99% of the time. Otherwise, you're ending up with a full resuscitation that you don't need to know all of these things. But what I want you to know from this is the difference between primary and secondary apnea and how important it is that if a baby, you have no idea, you have absolutely no idea what they are going through or if they're in primary or secondary apnea just by looking at them, because they look exactly the same. The only way to know is they don't respond to suction and stimulation. So if a baby transitions, you need to know. So this is the old Ballard exam that used to be used, and they would do this majority screening and try to figure out what is, given the weeks of what the baby is, what's their gestational age. So now instead of using this APGAR score, doing this whole Ballard score to then figure out the maturity, they now actually look at the weight based on the weeks. Okay, so if you're 35 weeks, let's say you deliver 5 weeks early, even though you're early and considered preterm, you could still have a large for gestational age baby, okay, or appropriate, and it's appropriate for a 35-weeker or small. So you could have a preterm / SGA baby, a preterm / AGA baby, or a preterm / large for gestational age baby. But even if the baby's preterm, we know that preterms have issues with hypoglycemia, temperature control, glucose control, suck swallow. They can't quite figure it out. They have weak sucks. So we know they're going to have issues, and we're going to be following protocols and doing blood sugars. But if they also have some other things going on, it's important to know that. So then let's say at 40 weeks you deliver an LGA baby. What are you concerned about with large for gestational age? Hypoglycemia. What are you concerned about small for gestational age? Hypoglycemia. Isn't it funny? Both of those we're concerned about that, and temperature control. So any baby that falls into a protocol, so appropriate for gestational age is over term, 37 weeks and above, appropriate for gestational age, is not going to fall under a protocol. However, if you are preterm, AGA, LGA, SGA, you're still following preterm protocol. But if you are LGA, SGA, whether you're term or not, right, you're going to be following protocol. Does that make sense? So a term baby, if they're LGA or SGA, you're going to be following protocol. A preterm baby has some protocols associated with it under 37 weeks, but then you're also looking to see if they're SGA, AGA, or LGA. All right, and so there's different blood sugar protocols you follow for that. And here's a little baby with a pulse ox on, laying on their back to sleep. You can swaddle for the first 2 months. After 2 months, they break out of the swaddle. But we know baby's biggest area of losing temperature is through their head. So it's very important to have a hat on. And this baby's holding their little choo-choo. We used to call that pacifier in their mouth. So that's what I'm talking about, that gestational age assessment. And so there can also be early term, late preterm, postpartum, or post-mature. Sometimes those early terms, so 37 weeks, late preterm, 36 weeks, can act like really preterm babies. So even if they're term, they can sometimes act like preterm babies. Hard, always back to the same triad. Temperature, blood sugar, suck. Issues with all three of those. Why they can, sucking, not that they suck, why they can end up in the NICU. So these are the things that are going to happen in those first 2 hours after birth. Eyes and thighs, right? We give eye prophylaxis to make sure that there isn't bacteria in any of the vaginal fluid. We give vitamin K because they have immature livers and as a result of immature clotting factors. So we need those babies to clot. We try to promote bonding, especially during that golden hour. And we, make sure baby is breathing okay. Nice bulb syringe is what we teach parents how to suction. There's some eye stuff going in. Eyes and thighs really need to be done within the first hour per protocol. So things that we worry about with babies, right? Is there any sort of injury? In my clinical group today, we talked about Erb's palsy, which is where there's an injury to the brachial plexus and one arm will be kind of floppy. We always worry about hypobilirubinemia. That can be an actual big issue for babies, and we'll talk about that in the next thing and how we deal with that. And hypoglycemia and hypocalcemia. In what babies are we worried about hypocalcemia? And that's infant and diabetic mothers. Oh, that baby has a bruised face. Just by looking at that baby's face, you know what I can tell you happened? That mom had a precipitous delivery. She shot that baby out of her vagina, and when she shot that baby out of her vagina, all of those blood vessels broke in the baby's face. And so this baby, anytime you have excessive bruising, as it is at increased risk for jaundice or hyperbilirubinemia, because you have excess red blood cells, breakdown of red blood cells that need to be excreted, and that's what leads to jaundice. And there's a Billy check. That's how they do it. They actually shine it on the forehead, and it gives them an amount based on their hours. So you always have to look at a chart, because it's like based on their hours of birth, are they in a high score, low score, is it normal? Because you can see like 10 is really normal, once you're a few days old, but it wouldn't be normal in the beginning. So you have to refer to a chart and a logarithm for that. And babies with high bilirubins are actually treated with light. Isn't that interesting? Back in the day, they used to bring them out in the sun. But we know that light helps to break down the excess bilirubin. And why do we even care if there's excess bilirubin? Because it can actually go into the brain and cause kernicterus and cause major brain damage. So that's the whole reason why you're doing this, is to keep a baby from having brain damage. So you can have pathological jaundice and non-pathological jaundice. And non-pathological jaundice is just sort of transient jaundice that can happen in some babies. Pathological, you're going to see when you have like ABO incompatibility and a lot of broken down red blood cells, and you really need to treat that. So they cover their little eyes when they're in there. And so babies are also going to be given a hearing screen test. They're going to be, so in Illinois, the state of Illinois, it's mandated they have a hearing screen test prior to discharge, and they also get what's called a metabolic screening test, and they're screened for a whole bunch of different metabolic disorders, and that we call it the PKU test, and it's really important that that's done prior to, it has to be done at 24 hours of age, and it's mandated by law. And there's all different kinds of things to prevent injury, and here's a hearing screen test, and here's a hearing screen test. We don't let parents walk in the halls with babies. They have to be transported in carts. There's obviously safety procedures, security procedures, things like that. If they have to draw blood from a baby, they will actually go ahead, and they don't want to do it in the middle, because look, you have these nerves in the middle and you can hit a nerve. So you always want to try to do it on the side. I don't like this picture because they're using a diaper to heat up the baby's foot. And you really should not do that. There was a lawsuit where they did that, and it caused severe burns on the baby. I don't know where it was, but it was one of those things I read in one of the organizations I'm part of. So you should really only use a heel warmer made for newborn. That would be a no-no in that picture. Here's a venipuncture. This is more often going to be done in NICU. Sometimes they will draw labs on baby and want an actual venipuncture versus from a heel stick. Here's Hugs tags. This is what we use in Northwestern, Hugs and Kisses. And this is one of those security systems for babies to prevent infant abduction. So babies some babies will get their first hepatitis vaccination while they're in the hospital. It depends on if their physician's office does that. Not all do. Some babies will also be circumcised while they're in the hospital. When you give an infant medication, you're giving it in the thigh, the middle, right there in that vastus lateralis muscle, right there. So kind of the thigh into the side a little bit, ideally. This little baby, what's going on with this baby? I don't know. Oh, gosh, I'm sorry. I'm like, why is the penis out like that? This baby is in sorry, it took me a minute to figure out what was going on here. This baby is in a tray. See how the feet are in the tray and the baby is swaddled and the nurse is holding the baby. This baby's about to get his penis circumcised. And they will use sucrose on, what do you call it? Pacifier. We always call them choo-choos. So pacifiers, and they have found that does not disturb breastfeeding when it's used for pain procedures. If a mom is breastfeeding, we do say to hold off on a NUR until they are until breastfeeding is well established. However, in this case, when it's used as pain prevention, it tends to work really well. Sometimes they'll put EMLA cream on the penis to numb it before. You never put lidocaine on a penis, right? Because you cannot put lidocaine on, right? You don't put them on fingers, toes, nose, or I can't think of what it is, or they might use lidocaine, but not epi, right? You can't use epi if there's bleeding. But they may do a little bit of lidocaine, sorry, not epi. If it's bleeding, you can't use epi to treat on a penis. They may do EMLA cream, and they often give Tylenol beforehand. And this is a Mogan clamp. No, this isn't, I'm not sure. This is a type of clamp where they go in and then they cut off the foreskin, and there you go. And this is a Plastabel. This is a different kind that is used. What we teach parents to do though is to use Vaseline gauze and cover the penis for the first 2 weeks every time they change the diaper, so the diaper doesn't stick, and it will actually like slough off yellow discharge, and that's normal. Again, bleeding, pain, unable to urinate, all of those things would not be okay. It's very, very important that we always educate parents in that 6 to 8 wet diapers a day once their milk is in their home, 1 to 2 soft stools a day. The best way to tell if a baby is getting enough is through looking at their output. Babies should be eating every 2 to 3 hours. It is not normal if a baby isn't doing that. Oh, the baby's getting a bath. This baby's swaddled in the crib. There's kind of a lot going on there. I'm not sure I like all that loose blanket and things like that, but the baby is awake. So these are just things that you're really going to be discussing with the parents and talking about. And here's just nurses with the baby. This is a cord clamp, and this will come off when they go home, and it does just then have to rot off. And it takes like 2 weeks, and eventually will rot off. So again, bleeding, odor, things like that would be things to talk to parents about. So there you go. Now we're going to talk about high-risk newborn in another one. Oh my gosh, seriously, what is wrong with me? Sorry, bear with me, I'm almost done. Escape. I don't know.